I was going to record this session. So here we go. All right, Kaylee Sears, here you go.
Don't forget to unmute, Kaylee.
Kaylee, you're muted.
Y'all, I am not good at this. It is almost 5 o'clock. I'm Kaylee. I'm the peds nurse in Fort Worth. Most of you I know, but those of you that I don't, I'm your main peds girl. I've been with CHOT for about 4.5 years. And I was in the pediatric ICU at Cook before that. And then in my former life, I was a teacher, so an elementary teacher. So kids are what I do. We just kind of wanted to get on here because our census does grow up and down, and we're kind of in that like staying stable. But we've gotten a lot of questions regarding peds, and we have a lot of new nurses and things like that. So we kind of wanted to give y'all a little overview because it can be super confusing. First off, I want to say that peds is very genetics based. A lot of the diagnosis and syndromes that you see are genetics based. And so, you could have two trisomy 18 kids and they look completely different because of the additional genetic things that they have going on. So it's very difficult for us, for me, for Dr. Godfrey, Jenny, Dr. Wesley, to say, this is what you can expect with a trisomy 18. This is what you can expect with a Zellweger. It's all very different. And there are a lot of times that I Google diagnosis because I've never heard of them. We do have our cancer kids, those kinds of things, but mainly genetic. So the differences between peds and adults. When you have adults, we are their only healthcare providers they see. We're it for them. For peds, Texas is one of the lucky states that allows concurrent care. So that means they get hospice and they can still go see their PCPs, their neurologists. They can get their therapies. Depending on insurance, they can go into the hospital, all of that kind of stuff. And so that's really important when it comes really at admissions. That's when it becomes really important because families ask, can I still go see these people? Can I do this? And in the past, we've had some nurses not knowing say, nope, we're it. This is it. And then parents freak out and they don't want hospice and then we kind of have to backtrack and, kind of clean up the mess a little bit, which is okay. It happens. It's not a big deal, but we're hoping that we can minimize those things just to provide overall better patient care. When it comes to things that we provide equipment wise, we can provide everything equipment wise that we do for adults, except for GI things. So we don't provide NG tubes, we don't provide G tubes or PEG tubes. We don't provide formula, we don't provide the pumps, anything like that. But respiratory wise, nasal cannulas, oxygen concentrators, suction, hospital beds, wheelchairs, all of those things we can provide. A lot of these kiddos will come with more aggressive treatment equipment like cough assist, CPT vests, Airvos, BiPAP machines, all of that. All of that is covered by concurrent care. And the people that cover that, this was a question in the first one, is home health. So a lot of the kids that we get, it is Cook Home Health, and they coordinate all of that. I don't coordinate that equipment. I work very closely with the palliative care team at Cook to coordinate that, but we are not responsible for that. With supplies, we don't really get any supplies for them. Diapers, we cannot cover diapers unless it is like an 18-year-old who is incontinent because of cancer. If it's been if we have a 17, 18-year-old who's incontinent because of chronic, he's a chronic kiddo, a genetic, a kiddo that's had this disease or syndrome or diagnosis for their whole life, like we're not going to cover those. But if it's like a recent cancer diagnosis or something like that, we will cover that. Infants, we do not cover diapers, wipes, anything like that. If you have a family that is definitely in need, though, like needs help, please let us know, let our social workers know, because we can help get them in contact with WIC or other resources like that. Meds are all weight-based. We don't send out like a just standard comfort kit. We try to get morphine, lorazepam out there in the home, but it is all weight-based. So just ask your parents, hey, what's the most recent weight? If it's a new admission, obviously go off the chart. I try to update my weights as I can, but some of them are a couple months old, and that's okay. Now, that doesn't mean that everybody needs to carry an infant scale or try to get a kid up to weigh them because you need to tell Dr. Godfrey a weight. That's okay. And in our older kids, it's okay to, best guess judgment on weights. They're just more weight based.
Or ask the parents.
Or ask the parents. They might know. Les, we did this earlier, and so now I've forgotten everything that I've talked about.
The parents is a resource.
Yes, the parents. Yes. So going back to like a lot of the syndromes, I don't know. A lot of our genetic kids that come on are special cases for them. Like they might be one of 10 in the United States that have this. I'm just throwing that number out. But it is okay to go in. And if you're there for pain or respiratory distress or even seizures, it is okay to say, what is their baseline when they're breathing? How is this different than what you normally see? Or what caused you to call us to make this visit, kind of thing? Because a lot of my kids who, if you didn't know them, you'd walk in, you would think they're in respiratory distress, and that's their baseline. Or they have seizures 10, 11, 12 times a day, but that's baseline for them. And so using your parents, the parents are the experts with these kids, and that's okay to ask them questions. Don't go in and say, well, I've never done kids. Like, I don't know anything about kids. Just say, that your child is not my patient. Can you please educate me, or can you please describe like what their baseline is so I know how best to treat your child and fix whatever symptom we have going on. It is also okay to say, I don't know. Let me call Dr. Godfrey. Let me call Dr. Wesley. Let me call one of my other nurses or managers to see, one, if a med is, if we can cover a med, if we can cover equipment, or if you just need a question answered about what you see going on. That is so totally okay. And I still do that. Sometimes I'll call Dr. Godfrey. I'm like, I have no idea about this kid or this med. So I think that is all very valid and very okay. Kids dying is not normal. It can be emotionally hard. It can cause anxiety. It can be sad. But these kids deserve the same type of care that you would give an adult, because reality is kids are dying. And so when you go in, Dr. Godfrey talked about this in the last one, and I'm so glad she brought this up. Like, give yourself a pep talk before you walk in there. And if you need to call one of us, or if you need to call your social worker or your chaplain, I can tell you Jeremy's the best pep talker that I call when I need one. Call him and put on that brave face and fake it till you make it. And then you get in the car and you can lose it if you need to. But just don't do that in front of the parents or the family, because they're already in a really crappy situation. And then if they see this healthcare provider that's supposed to be helping them come in and is not able to compose themselves, that doesn't really help the situation.
Oh, Kaylee, you're muted. Did you mean to mute?
No, I did not mean to mute at all. I'm sorry. I said I think that's it. I didn't know if anybody else
Oh,
had
okay. No.
anything to input or if you thought I missed anything, Les.
And I can give the Dr. Wesley pep talk. I mean, y'all went to nursing school, y'all are nurses, you did a rotation or had a little bit of time with PD. So, it's you can do it. It uh, and like Kaylee said, if you need a pep talk, do it, pep yourself up in the car, call us. We can help kind of talk you down before you go into the visit. Um, and then if after the visit, I mean, if it was, because this is not normal, like Kaylee said, if after the visit you need to debrief, call. You rely on your team. Your team is there for a reason and they're very valuable. If you need to call the social worker, chaplain, bereavement coordinator, or your PCM, or just the administrator on call, do that. But that is part of taking care of you after the visit.
Absolutely. Thank you, Doc. And thanks, Kaylee. Jenny, do you have anything that you wanted to add? I know things are maybe look a little different in Waco.
I think y'all covered most things. Really, I mean, just like you said, just using your team as a resource. We're all here to help each other, and support each other in it. And so, yeah, that's really, y'all covered
You
everything.
need to listen to it. Please do.
Um, One thing that I thought about and I didn't, it just popped into my head, that I did not think about in the first one. Really most of if somebody's going to go see a peds besides the admissions, it'll probably be a PRN or a death. Um, for the deaths, one thing that I like to talk to the parents about, like at time of death, depending on the size of the kid. If it's a baby or, somebody that you feel like the mom or the dad can carry. I have had a lot of parents um, tell me after the fact that carrying their child out to the funeral home, to when they come to get them, to the stretcher or to the car, with babies, they typically bring bassinets, like a, is it Moses bassinet? I think that's what they call it. One of those, carrying that child outside, and giving the funeral home their child, emotionally, um, kind of shifts their mind from somebody's coming into my house and taking my child and doing those things. And so I kind of like to talk with the families about that, of like, hey, you have this option if you would like to do this, if you would like to carry your child out. I also ask them, for babies, do they have a favorite onesie? Do they have that, or do you have a favorite onesie for them? Or for older kids, do they have a favorite blanket or something like that that you would like to wrap them in, or like take to the funeral home, that they can obviously get back? Those are really, like at time of death. Those are some really special moments and things that we don't necessarily do in the adult world. One, because we can't carry them out, but just those little touches really do help the parents in the grieving process.
Yeah, I can't even imagine, obviously losing a child, a baby. So I'm sure there is probably a lot of symbolic, giving and
Mm-hmm.
versus being taken away. So that's really good. That's a good point.
Another
Oh,
thing, oh, go
go
ahead,
ahead, Doc.
Les.
No, go ahead, Doc.
Another thing is, should they have a crisis or whatever and go into the hospital? Um, the Medicare concurrent care kids can go into the hospital. They don't need
Yep.
to be discharged. Um, most of the, I mean, I would say all the insurance kids, they do need to be discharged. So that's a big difference between insurance and Medicaid kiddos. And then the Medicaid kids, depending upon what's going on, as long as we can continue their plan of care, and if it's just something acute, usually they're home within a day or two, but we can usually keep them on service.
Right. And there's a, what is it, a 14-day? It's
14
the
day. Yeah.
14-day rule, right? So they,
Yeah.
if they're in
And
the
typically,
hospital
like,
for 1 days,
yeah,
they have to
typically Dr. Godfrey and I watch that pretty closely. So y'all wouldn't have to worry about any of that. But just because they go to the hospital, if they're Medicaid, they can stay on service.
perfect. All right. Well, we're going to jump into questions if you guys are ready. The first one is from Kelly. She says, how do we handle DME supplies and medications? And are meds typically listed as concurrent care payer source unless we get from Perone's like Comfort Kit and symptom management?
So it kind of just depends. Like obviously our typical comfort kit ones that we would do, like morphine, lorazepam, antidepressants, things that we, all of that. See, some of like the very basic seizures, if they didn't come on service, um, with seizures, we will cover those. Really just I still have to call Dr. Godfrey a lot of the times of, are we going to pay for this? Because there's so many kids that have like off the wall seizure medications, or certain respiratory meds that I don't even know how to say, um, let alone what they really do and how much they cost. So it really just depends. Um, Also, we also don't, or Dr. Godfrey, especially with these seizure meds, like to leave that up to concurrent care on tweaking those meds, because those neurologists have been working with them probably for a while on finding the right combination. And so we don't want to mess that combination up. For Fort Worth, we have a really, really great working relationship with palliative care. I talked to at Cook Children's. I talk to them probably 4 times a day. That's why I was late getting on here. They were calling to tell me about another kid um, in the wings. And so our PCMs have their number. And so if it's on the weekend, they have on call docs. They know how to get in touch with them on certain things. And they can get in touch with their neurologist or their pulmonologist or their, whatever, if they feel like they need to.
Awesome. Okay, next question is from Amanda. She says, do we provide cribs or bassinets for babies coming on service?
Unfortunately, we don't, because in the eyes of Medicaid, that is something that they would have to have anyways, if they weren't on service. And so that kind of goes along with like the diapers and stuff, like those things they would need no matter what. So we don't. But if you have somebody that you feel like needs that, please let us know. Please reach out to your social worker or something like that, because we have a lot of resources that we can try to get one for.
Yeah, and a lot of these parents of the, especially the genetic kids, are told your baby will probably never leave the hospital, so they don't prepare. But there are resources, and we can give them lots of resources. And if it's a one-off, we do have fundraise. We have
Yeah,
fundraise.
we have money.
Yeah.
Yeah. Also, with that, thank you, Dr. Godfrey. We are seeing more and more of these genetic kiddos being told they're not going to make it through birth or go home, and they are. So parents don't have car seats. We can write, if that's what's holding them up from discharging, we can write a letter. And some kids can't be in a car seat. They can't travel home in a car seat because of the either that position would cause them to die faster, or their body can't tolerate it, or anything like that. We have written many letters of like medical need for not or medically not riding in a car seat. Does that make sense? Like, so the mom can hold the baby on the way home.
Right.
That way, if they were to be pulled over by a police officer, they can present that, and like parents won't get in trouble. So if you have that, just reach out to us, and we can definitely get that for you.
Kaylee, and that brings up a question that I just popped in my head. Do you guys ever use transport like non-emergency transport for kids, or is there even a
They,
non-emergency that will do it?
I don't even think there's a non-emergency that will do it. Most of our kids that we need a transport for, teddy bear transport with Cook will transport them home. So they in palliative will coordinate all of that.
Gotcha.
But some of these
Um,
like outliers, like the NICUs and things like that, that aren't at Cook, um, teddy bear normally won't transport them. So it's kind of on parents.
gotcha. All right. Next question is, are peds able to have separate home health also while on service?
Um, so it's not home health in the sense that you would think of like an adult home health. They can get PT, OT, speech, things like that. They can get private duty nursing, but to have another nurse like me come in and assess, no. So it's but peds home health is different than adult home health. So yes
Like
and no.
home health would manage the vent.
Mm-hmm.
Home health would be maybe managing the G
Like
button.
the yeah,
Yeah.
yeah.
Okay, so we're in adults, we would be managing all of those things, and we would be managing their like respiratory devices and things like that. That would be more where the home health piece would come in. Is that
Mm-hmm.
right?
Mhm.
Yeah. Also, I forgot to mention this in adult or in Texas, and Medicaid, uh, pediatrics is 20 years, 364 days. So the day they turn 21, that's when they're adult. Everything under that is a pediatric patient.
Yeah, and we talked a little bit about that earlier and how difficult that kind of a transition is because they are no longer at that point, they're adults, right? So they can't get concurrent care. They kind of have
Mm-hmm.
to make a decision at that point, huh?
Yeah.
Next question is, do we offer palliative care for pediatric patients? And
No.
I can tell you we don't right now. As of right now, we don't. Um, let's
In
see.
Tarrant and Dallas County, there are, the hospitals provide wonderful palliative care. So
Yeah. So
it's not, yeah.
they would see them through Cook or Children's or something. So it's not as big a deal like the adult world.
So, and you kind of already half answered this because of why you were late, but what does it look like to coordinate care? We know in the adult world, a lot of times if they don't have an attending physician, we're updating, maybe their primary doctor with regular updates. Um, if they do have an attending physician, then we've got our hospice medical director and we've got the attending physician that we coordinate care with. But in peds, what does that look like? Because you're talking about coordinating with hospitals and home health, and
Yeah.
so I
It's a
would
lot.
imagine a significant amount of your time is spent
Yeah,
doing
it's a
that,
lot,
right?
probably half my day every day. I don't think people understand how much coordinating goes on. And even before an admission, there have been some kiddos I'm spending 20 hours before the kid gets home, coordinating, getting him home, what's needed, all and making sure everything is in place. So I work very closely with our palliative care team. If it's a kid that comes from a NICU that's not at Cook, so say they're not at Cook, say they come from Harris or Baylor, and they go home. If it's an infant that I think, okay, we're going to be here like weeks or a month, I probably won't make a referral to Cook palliative just because those are extra visits they have to see. Those are extra, time away that parents are going to have to do. Um, and it's not really going to benefit them very much. But if it's a kiddo that I think, okay, we could be here for a while, then I will make that referral to palliative. And so then they can help get, if they need to see neurology or referral to pulmonology, they can do all of that. But palliative is really who I talk to the most, because they have access to the specialists way better than I do. And so we go back and forth. They update me on their visits or neurology, if any of the specialist visits, they'll give me updates. And then I'll update them on, hey, this is what's happening. I'm about to discharge this child. This child's looking bad. All of that kind of stuff. Also, if
Okay.
a patient dies and they're on palliative care at Cook, you need to call them and let them know. even if it's after hours.
Okay, so part of that notification process would be their palliative.
Yeah.
Okay. The
Hey,
second part of
Kaylee,
that question.
Yes.
Go ahead.
sorry, about the notification after hours. I've run into, and I know you and I have talked about this, Kaylee, but I've run
Right.
into where the answering service is like, well, we're not paging. Do you need something right now? And I was like, no, I just need to pass along the message that, this patient has passed. And they're like, well, we're not waking up the doctor to tell them that someone died. And
Well,
so,
yeah, you can and I get that. And just document that. The reason they want us to notify them, like middle of the night, I would say, okay, wait till, whatever. Um, they just don't want, they know they're declining, and so they will call like on Monday morning or Tuesday morning to kind of check in. And especially if I'm not working, they just don't want to call the family and be like, "Hey, how's your kid doing?" And they're like, "He died last night." Like
gotcha.
that. That's the reason they're wanting that. So, um, I mean, I get the pushback, but also they want to know.
All right, I'll try. I'll just keep trying.
Just keep trying, or just send me a click or
Document.
somebody.
Yeah. Document your effort. That's the main
Yes.
thing.
Got it.
All right. Um, let's see. Oh, the second part of that question that I didn't see when I didn't scroll far enough. As far as referral and sources and marketing, are there specific providers or types of doctors to target for these types of patients?
Do you want to answer that, or do you want me to? It looked like you were about to.
Oh, me?
No, Les.
Oh, go
No,
ahead,
no,
Les.
I don't know about the how much we market to cooks, and I mean I know you obviously y'all have a relationship with them already, but
Mm-hmm.
are there other hospitals like NICUs and things like that we should think about, or is this one of those
Yeah.
things that they know if they need that
Yeah.
we
No,
are available? I don't know how that works.
yeah, no, I definitely think that we can do a better job at marketing.
We
In the
don't
past,
need to market to cooks. They
no,
know us.
yeah, Cooks knows us. Like that's not it. I would say, in Harris, I feel like Big Mama Harris, like we're in there enough that they know us. Um, I think we can maybe build that relationship a little bit stronger in the NICU, which I feel like some of our liaisons are trying to do. Some of their doctors are set in their ways about certain things, and so that's kind of what's holding us back. Child life specialists, but fighting for that. Um, but I think Harris Southwest, their NICU has expanded. It's bigger than what it was when I had my first child. So they're getting a little bit higher acuity kids. I think Baylor Alliance has sent us a good
The
amount.
medical cities, yeah.
The Medical City Alliance, all of that kind of stuff. So I mean, I definitely think there is a market. Now, do we need to go to pediatricians and things like that? Absolutely not. But I think like the NICUs for sure, we need to do that. PICUs, they're going to get sent to Cook. So we don't really have to worry about that. But definitely the NICUs, I think we could definitely do a better job at getting in there.
Okay, awesome. Thank you. We talked about this in the first session as well, but what's the difference in assessing pain? So we know we are trained, a lot of us, we even train all of our aides. Hey, here are the nonverbal signs of pain when somebody can't
Mm-hmm.
speak. We're looking for furrowed brows, all the grimace. We're
Yeah.
looking for all those things. What do we look for in, let's say, a baby? Because to me, and I had a baby a long time ago, but I don't remember knowing. I just remember being so young and freaked out that, I don't know if my baby's in pain. You figure those things out. So how do we do
Right.
that as somebody walking into that situation?
So kind of like the baseline thing. Well, one, there's the FLAC scale, FLACC. You can definitely use that, but sometimes that's hard to use if you don't know that patient. And so I just ask the parents, hey, is this their normal cry? Is this, you know this baby, is this a hunger cry? Is this a discomfort cry? Is this a really pain? Babies and nonverbal children will do kind of the same thing. They'll kind of clench up like babies when they don't feel good. They get in a ball, like they get tight. They bring everything in. They will guard. They will furrow their brow. They will do all of those things. Obviously, if the baby's screaming and crying, like don't look at vital signs because their heart rate's going to be up because they're screaming and crying. But in our older kids, if they're nonverbal and they're kind of laying there and you're questionable if they're in pain, like look at their heart rate, ask, hey, is this their baseline? Because most of those kids will have pulse oxes. We don't provide that, but most of them have pulse oxes. And so parents know kind of what their baseline is. And so really, really rely, use your judgment, but also ask parents, what's their normal, what do you look for when you're trying to determine pain?
Awesome. Another thing we talked about earlier is how do you go about honoring a child's voice, a child's wishes? We know that the parents of minors, they're ultimately the ones that make decisions, but how do we bring them in and give them some level of control in that situation, I guess?
Yeah. So first, and I didn't talk about this in the first one, because the question was asked a little bit different. Make sure that the parents are okay with you talking about their prognosis. And if they know they're dying, or if some kids don't even know they have cancer, like that verbiage which whether I believe or you believe that's right or not, that's the parent's choice. And so you need to confirm that before you say anything to the kiddos. If they do know, and they voice something to you and it's like they don't want to be doing whatever they're doing or whatever the parents are choosing them to do, like if the parents want to continue more aggressive things, just try to facilitate that conversation. If you don't feel comfortable facilitating that conversation, and it's one of my kids, just let me know. And the next time I'm there, I will try to do that. There's also some really cool resources that I know Megan has. One of them's called like My Voices, My Choices. And there's another one that's like My Wishes, something. Both of them are age-based and developmentally based. And we have those. Some of them will have filled this out in the hospital, especially our oncology patients. But it goes through some of those like hard questions. And the parents can do that with the child, or we can help facilitate that, or like our chaplain or social worker can help do that as well.
Awesome, thank you. Let's see. You guys don't forget to put your questions in the chat or the Q&A. We talked again earlier about self-care, right? And how for a lot of us, we are dealing with patients that are sometimes in their 80s, 90s, hundreds sometimes, right? And so I think, learn to appreciate that someone has lived a long life and that, none of us make it out of here alive, right? So when we're seeing children, though, like you said earlier, you pointed out, it's not normal for a child to die, right? And so I know that has to carry, just doing adult hospice, we carry a certain amount of our own grief and emotions that are tied to our patients and our families, and that's just inherent with the job. So I can imagine that taking care of kids is even more kind of difficult because of the not being able to reconcile that a child should not be dying. So do you have any kind of strategies that you use for self-care and how do you set your boundaries and all that good stuff?
Yeah. So I am really good at setting boundaries. I'm also really good at compartmentalizing, whether that's good or bad. But with the boundaries, like I have on my phone, and if anybody needs help doing this, I can teach you how to do it because it's awesome. My phone at 5 p.m. shuts off to do not disturb. automatically. It is, I don't even have to think about it. And I leave it in my car, or on the counter by my fridge, where I don't touch it until the next morning. And it doesn't turn back on to do not disturb, or off of do not disturb, until 8 a.m. On Fridays, I keep enough charge on my phone to make it to Friday at 5 p.m. And I don't charge my phone until 7 a.m. on Monday morning. And that can be difficult because, I do have patients, like, especially over the weekends, they're declining. How are they doing? All of that kind of stuff. But if you're constantly available, whether it's for kids or adults, one, you're going to get burnout. Two, you're not empowering your family, your parents, your families to do it, to let them, like, they can do it. They don't, you're not at their beck and call all the time. Because if you do that, like, that's not giving them that power to care for their loved one. And we have great nurses. We have great teams. And so you not giving them, or teaching those families or those parents, like, call the office. You're almost saying, like, if you're saying, just call me, I'll answer whatever, that's giving that, whether you mean to or not, like, false sense of, like, my team can't do as good a job as me. Which I know everybody here is great, but, like, our on-call nurses are amazing. And so just having that trust, that's my biggest thing, is the boundaries. The second one is, like, Dr. Godfrey and I talked earlier, sometimes we're sitting, if we've had a really hard case, we're sitting at Papacitos at 4:45, and I'm drinking my water until 5:01, and then I order my margarita. And sometimes you have to do that. And so just, taking that time, and, my family doesn't understand what I do. They can't comprehend what we see, even for adults, like, what we see on a daily basis. Like, our normal is the worst day of everybody's life, like, of somebody's life, especially for the kids. And so I'm saying, you don't have to be best friends with the people you work with, but, like, being able to talk to people that get it is very important. So
Yeah, the debriefing is very important. Taking your PTO.
Yes, use it.
It's important, and to take care of yourself and do that.
You can't make me.
I think I have 5 minutes of PTO right now.
Well, Jenny, do you have anything in particular you do to kind of decompress or cope?
Honestly, exactly what she said. Sometimes it really is just sitting in a parking lot eating fried chicken some days, not all days. But it really is just making sure that you take time for yourself, whatever that looks like. Some people that looks like just sitting down and, just watching TV. Some people it's yoga. You just never know. You have to find it for yourself. But once you do, it's important to keep up with it for sure.
Awesome. Let's see. Sorry. What are some ways you involve siblings in the care process while keeping that communication age appropriate? I imagine that's challenging, especially when you have a bunch of kids with different ages.
Yeah, it definitely can be. Again, it's kind of asking the parents how much they have told the siblings, and how much they want the siblings to know. That is, if you're not used to taking care of peds, I wouldn't say, like, jump into that on a PRN visit. But if you feel like there needs to be some discussion, please let one of us know, whether it's the chaplain or the social worker or me, Dr. Godfrey. I love Dr. Godfrey. She will make house calls for me if I need to. And so if it's someone if I happen to be out of town or something, and she's able to, I know that in the past that she has, and just helped have those conversations.
And
Go
kids,
ahead.
and just educating the parents. Kids are brilliant. They know what's going on. And so if the parents are kind of not having those conversations, it kind of makes can make fear escalate. Kids know they're sick. Kids know that their friends aren't doing things that are happening to them. So it really helps build trust and de-escalate anxiety to have age appropriate, honest conversations.
Mm-hmm.
Not us, the parents, because yeah, I mean, we can assist or facilitate with wording with the parents.
Mm-hmm.
Yeah.
Awesome. How does the team support families after the child dies? Obviously, we know about bereavement. We know what that
Mm-hmm.
looks like. Does pediatric look any different?
Um, Really the biggest thing for us, and I think Jenny can attest, we kind of talked on this last time, and I think she kind of said the same thing. We automatically make kids bereavement moderate or high. There's not going to be a low bereavement risk because it's just not. We also have a lot of great grief books that we can I try kind of when we're in this, especially if there's siblings, as we're kind of transitioning, that kind of stuff, I try to mention. We're kind of limited on copies of things, but if it's a family that you feel like can afford it, I'm kind of like, hey, this would be a great book. This would be a great resource. So we're making those extra calls after we, the Warm Place in Fort Worth is an amazing resource for kids, and the Warm Place is great for kids of anybody who died. So even some of our adult patients, if they have kids or grandkids that were super close to them, they can utilize the Warm Place. It doesn't just have to be siblings, and so just kind of providing those resources and checking in with them a little bit more often.
Okay. And the last one I have right now, unless anybody types something new in, is, I'm sorry, I think I have two more. If a patient comes on, they've got concurrent care, obviously, usually they'll have a like social worker that works with them. Do
Mm-hmm.
they get to keep that social worker from the
Mm-hmm.
hospital or home health, in addition to our social worker if they want?
Yeah, they do, which is great because, like, right now we have a patient who, our social workers are amazing, but none of them specialize in just peds. And so, we know of our resources that we have that are typically for adults that can be used towards peds, but those pediatric social workers, especially like the palliative care social worker and stuff, can really be utilized very well because that's all they do is kids. So they have a whole nother list of things that they can do.
And my guess is they've already probably
Mm-hmm.
established a relationship, and so they
Yeah.
probably already know and have identified a bunch of those needs too.
Yep.
Okay, let's talk about, because we talked a little bit about, we had some questions about, oh, Jenny's got to go. Thank you, Jenny, so
Bye,
much. We
Jenny.
appreciate
Of
you.
course, sorry.
And
Bye, y'all.
no, you're all right. We'll see you next time we're in Waco. The last question that I have, unless people add questions, is how have we utilized volunteers for our pediatric patients and families, and how might we do that in the future and involve more volunteers if we can?
Yeah. So this is a really tough one. And I can speak for Jenny as well because she talked about this story earlier. I have never used a volunteer. Because the families are already like, I have to sometimes pull teeth to get the chaplain or the social worker in there. And so just to add another person that they don't know, that's not a healthcare or healthcare related provider is very difficult. And because a lot of these parents are running hospital rooms in their house. So for them to be like, hey, here's a volunteer to sit with my child, that, I mean, that's just, you just can't. And parents are very selective, even with siblings, um, of having somebody come in to introduce them, during this process. It's just
Strangers,
very,
right?
it's just
Yeah.
very weird. And so Jenny said that she had one. She's only used it once, or had a volunteer once who was like a social worker at Baylor. She was in school going to be a social worker or something like that. It was an older child who was on service who had siblings that I believe were a little bit older. And that person came in and did memory making things with the siblings. So almost kind of like a child life specialist kind of thing for that person, but that's the only time. So as much as I love our volunteers and I think they're great, I think peds is just really hard to get in the home.
For sure, for sure. And then I had one that I didn't see pop up. If a pediatric patient comes to the inpatient unit,
Mhm.
what HME or furniture do we provide? Like if we had one go that was a baby,
Mhm.
what will we do? Have we ever had that happen, first of all? And
So
if
we
so, what do we
have,
do?
so they have to qualify for GIP, just like an adult would. Um, at when we had James L. West, there was a child room. So there was a crib in there. There was a smaller bed. It was painted blue. It had animals on the wall. So we did have that room. That's where they would go. Now that we don't have James L. West anymore, we're kind of limited. Um, I would hope that we would be able to get a bassinet or something, or a crib,
I'm
a
pretty
crib.
sure the South House has a crib,
Okay.
like
And
a crib on wheels that they can, offer to the
move
family.
somewhere. Yeah. And you would like South House would not be responsible for like cough assist, all of those kinds of treatments, but just your basic suction, oxygen, things like that. And Consurgix does have pediatric like nasal cannulas, face masks, things like that, that if South House didn't have, we could call them and get for them. But and if they don't have a crib, like I think we should use some of our money to get one.
Yeah, I think so.
Even from
Probably already.
Walmart. Even if it's a Walmart
Right, yeah.
thing, like from Walmart. It doesn't have to be anything special.
It's not used frequently, but
Yeah.
Right.
yeah. And talking about GIP level of care, we also earlier talked about continuous care for PDs
Oh
and
yes.
how, number one, just like GIP, if we're even going to try to get it, they have to have the same need as an adult, the same symptom management needs. But crisis care is very difficult to get for pediatrics because
Hmm.
the crisis care nurses um, generally are not comfortable. So we can't, make sure you don't. We can try, but definitely don't promise crisis care.
Yeah. Before we're making calls, right? We gotta
Yep.
Yeah.
do some background work on that first. And then Kaylee, do you guys go visit if you have a patient in the house? Do you go down there and kind of round on them?
I can.
You obviously
Yeah,
wouldn't be doing
for
that.
sure.
Yeah.
Yeah, for sure.
Awesome. Okay. Well, I don't see any other questions. I'm gonna let if anybody wants to unmute, if you couldn't figure out how to type a question, if you want to unmute, I'll give you like 10 to 15 seconds if anybody wants to unmute and ask a question. Otherwise,
Oh, I did want to let everybody know. I mean, I know there's a lot of angst around like when we're admitting a pediatric patient, and of course it usually does tend to be after hours or on weekends. Um, if you don't get the diagnosis exactly right in home care, home based, that's not a problem. We can change it. If so there really are not mistakes there aren't mistakes that can be made that can't be corrected, um, as far as the documentation. We can all, and always ask your AOC. They can help with meds, DME. That's usually the biggest questions.
And I will say I try to have everything as much as I can in place beforehand. I have typically, especially if they're from Cook, already talked to the parents on the phone, at least if I haven't seen them. I will try to have DME ordered and in place. Cook is great about sending a few days worth of meds home, and things like that. So don't be scared about admissions. Also, because they can get concurrent care on admissions, please put Dr. Godfrey as the attending, because that way any med orders that we have, she can sign, and I'm not trying to chase down a neurologist that will never talk to me ever. So I just always blanket put her down, because they can still continue to see their other doctors, and things like that.
Awesome. All right. Well, I don't see any other questions. If nobody else has any questions, then I want to thank Kaylee and Dr. Godfrey and Jenny for joining us today and spending 2 hours out of their day to do two of these. So I appreciate it. If you guys do have any other questions or anything pops up, don't hesitate. Click me, email me, and I'll get those questions to Dr. Godfrey and Kaylee, Jenny, Dr. Wesley, and we'll get an answer, and we'll make sure everybody hears the question and the answer just like we did here. But I recorded this, so anybody that wasn't able to attend will be able to watch it later on. Thank you guys so much for everything you do. Thank you, Kaylee. Thank you, Dr. Godfrey. And we'll talk to y'all later, okay?
Bye,
Thank
guys.
you.
Thank
Thank
you.
you, Les.
Thank you.